15 to 20%.
It's a number that, honestly, when you say it out loud, it just kind of hangs in the air.
It really does. Because we're not talking about a complication rate for some massive trauma surgery or an experimental transplant. We're talking about the reoperation rate for primary breast augmentation.
At just 3 years.
At just 3 years.
Think about that. I mean, 1 in 5 women who walks into a clinic for what we all consider the bread and butter of our field,
Right.
they end up back on the operating table within 36 months.
It's a staggering statistic, and if you look at the historical data, that number hasn't really budged. Not in decades. We have better implants, we have high-tech sterility protocols, we have 3D imaging.
All these advances.
All these advances, yet the failure rate is just stuck.
And the easy way out is to blame the device. You hear it all the time, right? Oh, it was a capsular contracture, or the shell failed. But the reality we have to confront today is a lot more uncomfortable.
These aren't really device failures.
No. They're failures of planning. They're failures of education, of execution. It's the surgeon factor.
That's the hard pill to swallow.
It is. The FDA regulates the device, but there's no one regulating the practice of medicine in that room. The whole premise we're unpacking today is that we need a total paradigm shift.
Okay.
We have to stop treating augmentation as this single event, surgery day, and start seeing it as a defined process.
And the goal isn't just bigger breasts. The goal should be a 0% reoperation rate, which, I mean, when you're operating on healthy patients for elective reasons, that's basically an ethical imperative.
Exactly. We have to minimize iatrogenic damage we cause. So let's break down this process. It starts way before anyone gets marked up. It starts with the philosophy.
This is where you see that huge divide. You've got what's described as the customer service approach on one side.
And the medical approach on the other.
And that customer service model is, well, it's pretty common.
It's the what cup size do you want model. The patient comes in with a photo, an idea, and the surgeon says, okay, I'll give you a full C.
And you see these methods like the rice bag method.
Oh, it's a classic. But it's just flawed physics. You tell a patient, put a bag of rice in her bra to see what size she likes. Rice sits on the chest. An implant sits in the tissue. It's totally different.
And what about surgeons who just eyeball it intraoperatively? Yeah. Sizing with sizers until it looks right.
That's the subjectivity trap. It's just guessing. And it leads to the patient changing their mind later, or even worse, you're ignoring the actual tissue constraints.
Right.
If you shove a 500cc implant into a tight envelope because the patient wanted it, you are setting her up for pain or pressure necrosis down the line.
Just the move has to be towards something objective, the high-five system. You fit the implant to the tissue, not the other way around.
Exactly. And the king of those measurements is base width.
It's non-negotiable.
Absolutely. The base width is the footprint of the breast on the chest wall. If a patient has a breast width of, say, 11 centimeters, and you try to put in an implant that's 12.5 centimeters wide because she wants more cleavage,
you're asking for trouble.
You're going to get visible rippling on the side or somastia in the middle. You have to respect the footprint. But it's not just about width. We have to talk about the container.
The APSS, anterior pole skin stretch.
Right. It's a simple physical exam maneuver. You pull the skin just medial to the areola. If it's tight, that's a stop sign.
What does that tell you?
It means you cannot use a high-profile implant. You can't force projection on tight skin without consequences. And if it's loose, well, if the APSS is large, that implant is going to bottom out unless you plan for it.
But the one measurement that I think gets missed the most is the end to IMF distance.
Oh, absolutely. And it causes so many of those, quote, unexplainable bad results.
The distance from the nipple down to the inframammary fold. Why is that number so critical?
Because of how breasts fill, think of it like a funnel. When you pour sand, or in this case silicone gel, into a funnel, where does it fill?
From the bottom up.
From the bottom up. So if that end to IMF distance is short, say 4 or 5 centimeters, and you put in a large implant, the volume has nowhere to go down. The fold is too tight, so it goes
up.
Up. You get that upper pole bulge, that torpedo look, and the nipple points down. It's one of the worst aesthetic deformities you can create.
And if the distance is too long, the implant just sinks and the upper pole looks empty.
Exactly. This is how you pick the right profile. And this leads right into managing expectations. We have to be brutally honest with patients.
Things like, your breasts won't match perfectly, or you will feel the implant. And the big one, ptosis, is normal.
Ptosis sagging is a natural biological state. If a patient expects zero gravity perfection, she will be unhappy. If she understands the trade-offs, she's thrilled. Satisfaction is just reality minus expectations.
Okay, Let's move into the OR. We've done the measurements, now we have to make the cut. And we need to talk about infection. Because the way we think about the breast surgically is, well, it's kind of a lie.
We pretend it's a sterile field like a knee or a spine, but it's not. It's a clean, contaminated site.
Because of the ducts.
The lactiferous ducts, they're open to the outside world. They are colonized with bacteria, specifically Staphylococcus epidermidis.
And Staph epi's is the villain in the capsular contracture story.
It creates biofilm. And that biofilm is the #1 cause of contracture. This is why the whole debate about incision location isn't just about where the scar is hidden.
It's about bacterial load.
Exactly. So you take the periolar incision cutting around the nipple.
The data is pretty clear on this one.
It's practically screaming at us to stop. If you cut through the nipple margin, you're cutting through those colonized ducts.
You're dragging the implant right through the bacteria?
You are inoculating the device before it even gets in the pocket.
Yeah.
The contracture rates for perioral incisions are just statistically higher, period.
So the preferred approach is the inframammary fold, the IMF.
It's the control incision. It's cleaner, sure, because you don't cut the ducts. But for the surgeon, it offers something even more important. Visibility. You can actually see what you're doing.
What about transaxillary? Patients love the idea of no scar on the breast.
They do, but it's a blind approach unless you are very, very skilled with an endoscope. And even then, doing a precise release of the muscle along the fold, it's incredibly difficult from the armpit. You risk asymmetry.
Okay, let's get into the technique. The dual plane. I feel like a lot of people just think that means half under the muscle.
That's the old thinking, partial submuscular. But dual plane is more of a spectrum. It's about the relationship between the pectoralis muscle and the breast tissue above the fold.
So walk us through it. We're in the submuscular plane.
Okay, you divide the muscle origins along the IMF. That's your baseline, dual plane 1. But say the patient has a tight lower pole. If you just leave it, the implant will look squashed. You need that muscle to slide up.
So you start releasing the muscle from the gland itself.
Yes, you separate that fibrous interface between the pec and the breast tissue, and the ratio is really powerful. A few millimeters of release gives you a centimeter of muscle retraction.
Wow, that's huge.
It is. You release a little, the muscle snaps up. A dual plane 2 release goes to the lower areola. A dual plane 3 goes all the way to the nipple. You're tailoring the release to the tissue tightness. It's dynamic.
Now, while we're releasing muscle, we have to talk about the no-fly zone, the sternal border.
This is probably the most dangerous part of the dissection for the aesthetic result.
Why do surgeons even go there?
Aesthetic greed. They want better cleavage. They want to bring the implants closer, so they cut the muscle origins off the sternum to widen the pocket medially.
But the pectoralis muscle is like a window shade.
Exactly. It's under tension.
Yeah.
If you cut the medial attachments, the rails of the shade, the whole muscle just snaps up and laterally.
Window shading.
You lose all the soft tissue coverage over the middle of the implant, so now you see ripples, you see the edge of the device, and worse, you get animation deformity.
When she flexes her pec, the whole breast jumps.
It jumps sideways, it distorts. And you cannot fix it. Once you cut those sternal origins, they are gone.
Is there any safe way to get a better medial look?
Well, you can release the accessory fibers, those little wispy pinnate fibers lateral to the main trunk, but you have to identify that main sternal origin and stay far away from it.
And staying away from the sternum isn't just for aesthetics, it's about the monsters in the cave.
The perforators, yeah. There are massive blood vessels about 1.5 centimeters from the midline, and there's a specific warning about the second intercostal space.
If you see that vessel,
You are too high and too medial. Stop. If you nick that vessel, it retracts into the intercostal muscle.
feed the ribs.
Right, so you chase it with the cautery, and suddenly you burn through the pleura. Now you have a pneumothorax. You've just collapsed a lung doing a breast dog. That is a very bad day.
Okay, let's pivot to the common pitfalls, the things that create those botched results. One of the biggest is the relationship between an augmentation and a lift.
The lift with an implant fallacy. It is the siren song for inexperienced surgeons. A patient comes in with umposis, sagging breasts, and they think, I'll just fill it up with a big implant and it'll perk right up.
But an implant creates volume, not lift.
It's a weight. If you put a weight in a sagging sac, you get a heavier sagging sac. And this leads to the waterfall deformity.
Which is such a descriptive name.
It's exactly what you see. The implant stays high, held by the muscle, and the breast tissue just slides off the front of it, hanging down like a waterfall.
So what's the hard rule? When do you just have to say no to an aug alone?
If that N to IMF distance is greater than 9 or 10 centimeters, or if the nipple is below the fold, you need a mastopexy. You have to tighten the skin. You cannot just fill it.
Another big complaint is rippling, and we need to distinguish between the two types here.
Yes, you have underfill rippling and traction rippling.
Underfill is simple, right? The bag isn't full.
Like a saline implant that buckles. But traction rippling is more insidious. That's the capsule scarring down and pulling on the skin.
And this brings us right back to tissue coverage, the pinch test.
It's your early warning system. You pinch the upper pole, and if you have less than 2 centimeters of tissue, or less than half a centimeter at the fold, you're at high risk.
And here's the counterintuitive part I found fascinating. If a patient has thin tissue, the instinct is to use a high-profile implant to get more projection.
Big trap. A high-profile implant exerts more pressure per square centimeter. It pushes out harder against that thin tissue.
So it actually causes atrophy.
It thins the tissue even more. It's a self-fulfilling prophecy. If coverage is thin, you need a lower profile implant to distribute the pressure, or you need to add coverage like fat grafting.
We should also touch on chest wall anomalies, pectus excavatum.
The funnel chest. In those cases, the slope of the ribs points inward toward the middle, so gravity is just going to slide the implants into the sternum.
Creating symastia.
Right, so you have to leave more muscle attached medially to act as a bumper. And for pectus carinatum, the pigeon chest, it's the exact opposite. The slope is outward, so the implants want to slide into the armpits.
So it's all about respecting the unique anatomy of that chest wall.
Physics wins. Every single time.
Let's talk hardware. Implants. The old debate was saline versus silicone, but the modern debate is really texture versus smooth.
And this has been the biggest disruption in our field in the last, decade?
Because of ALCL.
Anaplastic large cell lymphoma, or Brody's disease, it's a rare lymphoma found in the scar capsule around the implant, and the data has linked it pretty specifically to textured surfaces.
Particularly that aggressive salt loss texturing method.
Yes, the theory is that the rough surface creates a kind of chronic inflammation which can eventually trigger the lymphoma.
And it's usually found in a late seroma fluid buildup years later.
Correct. It's very treatable. If you cache it, you remove the implant and the capsule, but it's still a malignancy, and because of this, the use of textured implants has just plummeted.
So why would anyone even use texture now?
Really, only if you are using an anatomic-shaped implant, the teardrop shape.
Because of rotation.
Exactly. A teardrop implant has to stay upright. If it rotates 90 degrees, the breast looks deformed. You need that texture to act like Velcro and hold it in place.
But for a round implant?
Smooth is the standard of care. A round implant can rotate 360 degrees and it still looks round. There is no benefit to texturing a round implant that outweighs the risk of ALCL.
Okay, we're coming to the end of the case. We've measured, chosen a smooth round implant, done a precise dual plane release, avoided the sternum. Now we're in recovery.
And here's where that surgeon factor really pays off. The recovery protocol involves, it involves jumping jacks.
I had to double check that when I read it. Jumping jacks in the recovery room.
It sounds absurd, but yes. Gentle, slow arm swings, mimicking a jumping jack. The concept is immediate mobilization, because fear causes stiffness. Patients are terrified to move. They guard their chest, their muscles spasm. If you get them moving immediately, they realize, oh, I'm not broken. My muscle is intact.
And because we used precise electrocautery release instead of just blunt force tearing.
The pain is significantly less. Which brings us to the other post-op point. No torture devices.
No straps.
No straps, no bands, no special compression bras. If you dissected the pocket correctly, the implant sits exactly where you want it. The pocket is the bra.
So if you need a strap to push it down...
You didn't release the muscle enough.
And if you need a bra to hold it up...
You release too much. It's immediate feedback on your technique.
So bringing this all back around to where we started, that 15 to 20% reoperation rate.
It's just unacceptable.
Yeah.
And the main takeaway here is that getting to zero isn't about having golden hands or just being lucky. It's about a reproducible process.
It's the high five measurements. Respecting the sterile field. Preserving that sternal border.
It's recognizing you can't force a device into a space that can't support it. If you follow the process, you measure, you plan, you execute precisely, you stop having complications that are really just errors in judgment.
And that is how we change the numbers.
It's the only way.
Something to think about before your next scrub in. Thanks for listening.